We've had a lot of guests on this program over the years who've weighed in with their views on how to improve Ontario's healthcare system. But to the best of my knowledge, only one has ever testified before a committee of the U.S. Congress. Dr. Danielle Martin has long been an activist for universal healthcare. She's a family doc and also Vice President of Medical Affairs and Health System Solutions at Women's College Hospital in Toronto. She has put her experiences and ideas for reform in a new book which is called Better Now: 6 Big Ideas to Improve Healthcare for All Canadians. And we welcome Dr. Danielle Martin back to TVO. Nice to see you again.
Nice to see you.
Well, you're not going to be shocked what I want to start with here. People know you.
The Senate.
You got it. People know you for a bunch of reasons, but I suspect for this reason above all else. Roll clip, please.
What length of time do you consider to be equitable when waiting for care?
Well, in fact, the Wait Time Alliance in Canada, sir, has established benchmarks across a variety of different diagnoses for what's a reasonable period to wait. And what we've found is that actually working within the single payer system, we can reorganize things. You know, I waited more than 30 minutes at the security line to get into this building today. And when I arrived in the lobby, I noticed across the hall that there was a second entry point with no lineup whatsoever. Sometimes it's not actually about the amount of resources that you have, but rather about how you organize people in order to use your queues most effectively. And that's what we're working to do, because we believe that when you try to address wait times, you should do it in a way that benefits everyone, not just people who can afford to pay.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
That was very sharp, that whole waiting list thing, yeah. How'd you end up before that committee anyway?
Well, the chairman of that U.S. Senate subcommittee was one Bernie Sanders, independent senator from Vermont, who's obviously well known for many more things now. At the time, he was chairing that subcommittee, and he was organizing a panel about what the U.S. can learn from international healthcare systems that have universal coverage. And so they organized a panel, and I was invited to speak about the Canadian healthcare system. I have expertise in that area, and they called me up, and I had some pre-vetting that took place. I mean, it's a pretty involved process. And then I came to be seated at that panel table that you saw, and there was somebody speaking about France, and someone about Denmark, and someone about Taiwan, et cetera. And I was there to talk about what the U.S. can learn from Canada, which is always a tricky place to find yourself, because you want to put your best foot forward and talk about the things that make you proud about your country. But I think in my case, I also wanted very much to be balanced in terms of the perspective that I put forward. I didn't just want to say, oh, everything's perfect. I wanted to acknowledge where we can do better.
Right, and I do recall at the time there were a lot of people who saw this clip, and I mean, it did go viral, and they were sort of saying, you go girl, well done. What did the American senator who you were after there, what was his reaction to your appearance?
I mean, he just shook my hand and left at the end. I mean, I don't think, you know, I wasn't really there thinking that I was going to change anybody's mind about how the healthcare debate should go in the U.S., and I don't think he expected to have his mind changed. You know, that was a bit of political theater. I talk about it in the book, you know, how I had to be pretty careful with myself about understanding what role was I being asked to play. And these guys were not really talking to me. They were talking over me to their public, sure. And I was playing an assigned role. But what it did do was touched a nerve in Canada that I was totally unprepared for. And the huge amount of reaction that I had, people who reached out to me, Canadians living all over the world, all over the country, handwritten notes, emails from people, media coverage. It said to me that Canadians are still really proud of Medicare, and consistently in poll after poll will say it's our greatest national accomplishment.
Having said that, you would acknowledge there are problems with it.
There are huge problems, and
that's why you've written the book.
That's
exactly.
Right.
I want to take you back now many decades, and I want you to tell us about your Egyptian-born grandfather and why his story kind of, you know, I think alerted a passion inside you that led to maybe where you are today.
Sure, and you know, it's a story that actually predates my birth. So my grandparents came to Canada in the early 50s from Cairo in a bit of a rush. They had 3 generations on the ship to Pier 21 in Halifax. My mom still remembers that journey. She was a little girl at the time. And within 18 months of arriving in Montreal, my healthy, strapping 40-something grandfather had a totally unexpected heart attack. And my family was plunged into essentially a decade of horrible medical experiences in the days of Canadian medicine before Medicare. And by the time my grandfather died in his early 50s, they were not just sort of destroyed from a health perspective, but financially completely destroyed. And my mom still talks about that experience in that it's her belief that the financial devastation and the way that they had to borrow money from family members and friends and the marks that that left on those relationships that never really healed, that it was that actually, in her view, ruined their family. So I grew up with that story. It's not the sum total of who I am or why I believe everything I believe, but it certainly had an influence on me. And it certainly led to my belief that, and I think this is a belief shared by most Canadians, that access to healthcare is something that should be based on need, not ability to pay. And that is a driving force, has been a driving force in my career, for sure.
And yet here we are now with 6 big ideas that you think we need to look at to improve healthcare in Canada. So let's get into them. The first you say, and this sounds like nothing to do with healthcare at all, relationships.
Right.
How is improving relationships within healthcare going to improve healthcare?
So I'm talking about 2 very specific relationships. The first is the relationship between every Canadian and their primary healthcare provider, usually their family doctor. And I talk a lot in the book about how that relationship can benefit people's health, that relationship over time between you and someone who comes to know you, who understands your ups and downs, your broader life, not just one part of your body or another part of your body, but the whole of you, how that can contribute to improvement in health over time, and how it can also make the healthcare system sustainable. But secondly is the relationship between that person's primary care office and the rest of the healthcare system. So as a family doctor myself, when I see patients who need specialty care or who have been going in and out of the hospital or who need care in the community or at home, it's my job to sort of be the quarterback for the whole of that person's journey through the healthcare system. And when those relationships are functioning well, the relationship between the patient and their provider and the relationship between the provider and the rest of the system, everything else works. And all high-performing healthcare systems are built around that core of high-functioning primary care.
The flip side of that, of course, is that if you can't get in to see a family doctor in a system where everything is built around that original relationship, we got huge problems.
That's right. And so I think that we have a lot of work to do in that area. We know, for example, and I talk about this, that in Canada, fewer than 50% of Canadians will say that they can get in to see their family physician on the same day or next day when they call with an urgent problem, which is how we've seen, just as an example, certainly in urban centers, the rise of the walk-in clinic, a convenient form of care, which I understand why people use it, but actually quite the opposite of what we would consider to be relationship-based primary care, very episodic, no relationship, no ongoing chart, no communication back, and not the kind of model that really, I think, supports high-quality healthcare. And so in the absence of those relationships, we see that kind of breakdown. So it's my view that we need to up our game in primary care. I say that as a family doctor, and I think that there's a lot of the work that we can do, and it's absolutely doable is part of the point that I'm trying to make. It's not magic. We don't need thousands more doctors. We don't need a ton more money in the system. We just need to organize a little bit better what we're doing.
Pharmacare, another of your ideas. Why is a national pharmacare plan, in your view, essential?
For this very simple reason that 1 in 5 Canadian households reports that someone in that household is not taking their medication as prescribed because of concerns about costs. So Canada is now officially the only country in the developed world with a universal healthcare system that doesn't include prescription drugs. And I think that that is shameful, frankly. I mean, in an age where we're trying to move healthcare out of the hospital to keep people well in the home, it's absurd that a person who's admitted to the hospital could have access to all of the care they need, including all of the medications, and the instant that that person sets foot outside the hospital on the sidewalk with a prescription in their hand, they're on their own. So we're now in a situation where we're paying for complications of chronic illness, for hospital admissions and emergency department visits for people who would be so much better off, and their health would be so much better taken care of if they could afford to take their medicines.
Tell me this, though. If you take the people who have a pharma plan at work, they got a drug plan through work, or they're over 65 and therefore they're captured by a
in Ontario, that's
in Ontario,
true.
or if they're a low-income person and therefore they get drug benefits as a result of that. That's got to be a huge percentage of the people in the province of Ontario, no?
Well, I think it probably is in the province of Ontario. The problem is that even in some of those public plans and in some of the private plans, the co-payments and the deductibles for some people are a barrier. So I have a patient in my practice, I call her Julie in the book, who received a couple of years ago now a diagnosis of MS, multiple sclerosis, and her medications cost $25,000 a year. Well, she's got a work plan that covers, she's actually self-employed, but her husband has a work plan that covers 80% of the cost of her medicines. But that 20% is thousands of dollars every year forever that they have to try to find. And so sometimes even having coverage
not enough.
doesn't mean that it's necessarily enough.
A national pharmacare plan would do what then?
So in my view, a national pharmacare plan should essentially bring medicines under Medicare. So for those medications that there is good medical evidence to support their use, not everything for everyone all the time, but a list of what's called a national formulary, or a list of medications that are well supported by medical evidence. When you go to the drugstore, you should present your health card, and they should give you your medicine and you should go home and take it.
Can we really do this in Canada?
Well, actually, we could do it, and it might even save us, it would save us billions of dollars in the private sector, because employer-based health plans are extremely expensive and people are paying a lot out of pocket. One of the things I wonder about is, in this ongoing dispute between the provinces and the federal government about, are we going to have a health accord? And if we're going to have a health accord, what's going to be in the health accord? And the discussion about pharmacare seems to have kind of fallen off the side of the table. And I would really like to see that reignited. I think it is so obviously the unfinished business of our healthcare system.
Another of your 6 big ideas, and this is a different kind of a quote. Don't just do something, stand there.
That's
which
right.
is the opposite, of course, of what we usually say. You advocate that sometimes the best thing to do for a patient is nothing. Explain.
Right. And it's a little ironic, because having just said that there are many people who can't access the health care they need, I now turn around and say there are a lot of people who are getting a little bit too much health care. But in fact, that's true. And let's come back to the example of medications. We know in Canada that 1 in 5 Canadian seniors, or about 20%, are being prescribed a medicine on the Beers list, which is a list of medications that should effectively never be prescribed to seniors because the risks outweigh the benefits. So we have a huge amount of over-prescribing, over-testing, and over-treatment that are going on in the healthcare system. And people are harmed by it every day. In the case of seniors, it increases the risk of falls, ending up in the hospital with a broken hip, pneumonia, et cetera. And so the repercussions on health can be very serious. So as we're talking about what we need to do to have a high quality healthcare system, I don't think we can only talk about what we need to do more of. We also need to ask ourselves, where do we need to be doing less? If something is known to improve health, of course we should do it, and everyone should have access to it. If it's questionable or clear that it doesn't improve health, or indeed actually harms health, then we shouldn't be doing it. And we very rarely have that conversation these days about how can we dial it back a little bit and sort of lay off people. Fewer investigations, fewer imaging procedures, fewer interventions and surgeries, unless we know that those things are actually going to improve the health of the individual.
I wonder how much the patient has to accept responsibility for that, because I think we've all heard stories of somebody who says, I got a headache, I want an MRI on this tomorrow.
For sure, and I do think actually, that there's no doubt that patient requests or demands factor into those conversations. I think we need to recognize that that's true for a certain category of things, your MRI example being a really good one. We know that there are huge numbers of Canadians who are subjected to MRIs for low back pain or CT scans for headaches, where those things would contribute essentially no useful information to the management of their case. And it's possible that often people are asking for those investigations. On the other hand, very few people walk into a Canadian hospital and say, I'd like a coronary bypass. And so there are some things actually where it's really up to us as the medical profession to say, we're going to be a little bit more disciplined with ourselves.
There's stories in the book that you tell about a patient demanding a certain kind of test and you saying, you don't need it, forget it. And they get mad at you.
Yeah, sometimes. Sometimes they get mad. Often, actually, what I find, and this has been an interesting learning for me in my practice, is I kind of get emotionally geared up for them to get angry, and then the person turns around and says, okay, well, that's great. If you don't think I need it, that's fine. And so sometimes we are afraid to have that conversation. I do actually think it comes back to big idea one around the relationship. I mean, when you have that mutual trust with someone and they know that you have their best interests at heart, I'm not trying to save the system $5. I'm honestly telling you, I don't think that this is of any benefit to you. Actually, a lot of people are really happy not to spend their time getting medical tests and procedures that they don't need.
For sure. What about the other side of the coin, which is the doctor who's terrified that he or she's going to get sued by a patient if they don't order this test and cover every single possible base?
That's right. It's what I call CYA medicine, or cover your ass medicine, in the book. And it is true.
Too much of that going on?
I think there is some. I'm happy to say that I think there's less of it on this side of the border than there is in the US. But it does happen for sure. And I think that it's one of the contributing factors in what is a very complex morass of, how do we come to, people always say the most expensive tool in the healthcare system is the physician's pen, right? And so that, what leads me to tick that box on the requisition form? Some of it is, what does the patient want or expect or demand of me? Some of it is my fear of being sued. Some of it is my, desire to get them out of the office more quickly, or whatever it is. And all of these things kind of come together into that one sort of tick box action. And I think that we're going to need to unravel some of that if we want to improve the healthcare system.
Another of your big ideas, and this actually harkens back to the performance you had in front of the Senate subcommittee, where you talked about the lines of people, tons in one and no lineup at the other place as well. Reorganizing what we've got going right now. And to that end, tell us a story that you tell in the book about a 75-year-old woman named Susan who ended up having a terrible demise courtesy of the healthcare system.
That's right. So Susan was an older woman, a widow, who lived in the center of the country, and she had a number of chronic medical conditions. And she ended up in what I call the revolving door of healthcare, where so many Canadians, particularly older people with chronic medical conditions, end up where she was being admitted to the hospital and then discharged and then readmitted and then discharged, and waited for a spot in a long-term care facility for weeks. And during the time that she was waiting, she became frail, and then she fell out of bed in the hospital. She broke her hip. And in the end, after 3 weeks in the intensive care unit, which was something that she had never wanted for herself, she ended up dying in the ICU. And it's a really sad case. It's sad, about that individual, but it's also sad because everyone who reads that story kind of says, oh, I know someone who's had some slice of that experience. And the thing about Susan is she didn't lack for healthcare. She got more healthcare than most of us would ever want for ourselves or our loved ones, but it wasn't the right kind of healthcare. What she needed was support to keep her in her home. What she needed was instant transition out of the hospital after that first admission into a bed in a facility where she could be rehabilitated and get back to her house. What she needed was for somebody to sit down and say to her, what are your goals? If it is looking like we're close to the end for you, where do you want to die? And we're so afraid to have those conversations that we end up instead putting people in these very resource-intensive environments that are of no benefit to them and that cost the system a lot of money. And so reorganizing those resources to make them more logical or rational, not in the rationing sense, but in the rational sense, in the way that we deploy them, I think could take us a long way. It turns out actually there's a lot of resource in the system, but we don't always organize it effectively.
We don't hear that story at all. We hear all the time from doctors, from nurses, from patients, from everybody associated with the healthcare system. This system is starved for funding, might be $50 billion a year in Ontario, but it's starved for funding and needs more money to be better. That's not the case?
Well, I think our experience, so let me start by saying, of course, there are always pockets of the system where more money would be very useful. But I think we have seen actually the experience in Canada of money flowing and not making a big difference. And so I think we have to be careful to think that money is the solution. Very often it's that reorganization of resources. I have seen new graduates coming out into the healthcare system and starting their practices who are, desperate for consults, specialists who can't fill their afternoon clinic as they're trying to ramp up their practices and, get enough people in their offices to make a living at the same time that their more experienced colleagues have a 9-month waiting list for a first consultation. Mm-hmm. That's not about a lack of resources. That's about poor organization. And as a referring physician, as a family doc, I have no idea how long anybody's wait time is, or how would I even know whether I should be sending my patients to the one or to the other. And so when specialists, as an example, come together in groups and share referrals so that your patient can be seen by the next available specialist, even just that act alone can significantly reduce wait times. But it does require some change within the medical profession, and it also requires a change among our patients, citizens, and what their expectation is about what does it mean to be referred.
I'm going to come back to that in a second, but on the money, I want to read this quote from your book. Sheldon, top of page 5, please. For every dollar we spend on healthcare in Canada, 70 cents comes from the government. Compare this to the UK, where 83 cents of the average healthcare dollar is publicly financed. In Norway, it's 85 cents. In France, it's 79 cents. It's only because we so often compare ourselves to the United States, which has the highest private spending, 48%, and the lowest public spending, 52%, on healthcare in the developed world, that we tend to think our public spending on healthcare as being high. By international standards, it is not. I'm trying to figure out how we, on the face of it, it feels like if we spent twice as much money tomorrow as we did today getting better mental health services to people, surely we would have better outcomes, and that would be money we're spent. Is that not the case?
Well, I mean, it's true if I guess you got to ask, let's take mental health services as an example. Is the problem with wait times for mental health services really about a lack of providers? Or if we were to expand public funding so that people could see not only, say, a psychiatrist, but also a social worker or a psychologist, in other words, team-based care, could we reduce those wait times using the same amount of resource? If we were to centralize the wait lists, there's a great example in Hamilton, Ontario, actually, of psychiatrists coming to a group of family physicians, a family health team, and providing consultations where the psychiatrist just sits at a table and the family doc goes through 10 cases with them, in an hour. And so you as the specialist can give me that advice. I can then go back and implement it with my patient and dramatically reduce the wait times. What about virtual consultations, e-consultations, telephone consultations? There's so much that we could be doing with the resources that we have to reduce waits or improve quality when it comes to mental health. Some of that may cost money or might have an upfront cost to put into place or something, but a lot of it is just about thinking differently about how we can do things. And we see little pockets and examples of this happening all over the place, like the Hamilton example that I just named. I had a patient in my office last week who had a cardiac issue and I wasn't sure what to do, and I just had a phone conversation with a cardiologist because there's a billing code now for telephone conversations. A specialist can give advice to the family doctor by phone, and in a few minutes on the phone so that person never had to leave their couch for me to get that opinion. There's essentially zero wait time. I had the answer on the same day. We were able to make those adjustments and move on. And so,
what's preventing more of that from happening?
So much of it is culture. So much of it is just we all kind of get up and go to work and do the same thing today that we did yesterday. And so, to be honest, that's a big part of the reason why I wrote the book, is to try to get people demanding that, physicians, patients, policymakers saying that actually there's nothing stopping us from doing any of this stuff. There's no massive barrier in our way. We just have to kind of get started.
Couple of more of your big ideas to fix healthcare. Ontario is now in the throes of an experiment about the guaranteed annual income. I'm not quite sure how it's going to roll out or when it's going to roll out or where it's going to roll out, but they say they're going to do it. If that happened, and if it worked the way the people who want it to work think it will work, right, what are the implications for the healthcare system? I
mean, we spent a lot of time talking about healthcare, and as you've said, it takes up pretty much half of our provincial budget. But actually, this big idea, the guaranteed annual income, if it works, would do more for health than anything else we basically do in the healthcare system. Income is the #1 determinant of whether people will be well or ill in their lifetimes. And so we know that illness is significantly concentrated among low-income people, and that improving people's access to income and therefore their access to resources has a very profound effect on their own health, on the health of their kids, and it's very, very significant. So actually, these, what we call the social determinants of health, are critically important, and doing something to reduce or eliminate poverty in Canada is probably the most important thing we could do if we want to improve the health of Canadians. And I couldn't write a book about health without talking about that.
It's pretty clear poverty makes you sick.
Absolutely.
The stress of just getting through the day will make you sick.
Absolutely. And the other thing that's clear is that for people who are low income, increasing their income even by a small amount has a dramatic effect on their health. So the experiment that was done in Manitoba in the 1970s on the guaranteed income, the MINCOME experiment, showed that in the community where they were, people had access to a minimum income, and it was a very small amount of money, in fact, reduced hospitalizations in that community by 8.5%. So I like to say, if somebody invented a drug tomorrow that reduced all-cause hospitalizations by 8.5%, we would put it in the water supply. So why aren't we talking about poverty reduction and the minimum income as a health intervention?
We had Evelyn Forget on the program not too long ago.
Yeah,
who did all the research on that. Okay, let's do one more here on innovation. Now, here's Innovation 101.
Right.
One way you get innovation is to get competition, get everybody competing like hell. The argument is, because you're championing a single-payer system, you are removing one of the incentives of competition in our economy, in our society, and therefore you are depriving the system of the very juice that it needs in order to innovate. True or false?
False. And the reason that it's false is two things. First of all, we don't actually have an innovation problem in the Canadian healthcare system. There are successful programs, little pockets of excellence. I like to, somebody said at some point, islands of excellence in a sea of mediocrity, right? So pockets of really terrific work going on where outcomes have been improved, costs have been reduced, people's experience is tremendous, whether it's for stroke care or cardiac care, or diabetes care, or mental health care. All of these examples exist in Canada, but they exist in like one community, in one place, one team. And so if you happen to be lucky enough to be a patient in that place, you're getting world-class standard of care. But what we're missing is the capacity to bring those examples to scale so that everyone has access to them. And actually, what's required to do that move from what we call the pilot project to the system solution, is collaboration, not competition. And so that's where we really need to put the infrastructure in place to say, when we know what the best way to do it is, how do we make sure that everybody starts to do it that way? To some degree, that's about standardizing things, but a lot of it is about spread and learning from what we know works.
I got a minute left, and I want to do one more quote from the book and one more comment from you. Along with nurses, rehab professionals, mental health professionals, and so many others, doctors roll up their sleeves every day to take care of people who need our services with skill and passion. But unlike many other groups, doctors often see themselves as separate from the system. Until they see themselves as part of it, large-scale change will be blocked. How do you get docs to see the bigger picture?
I think this is something that can only come from within the medical profession. It's not some edict from government or, enforcing employment status or something on physicians. It's about doctors saying to ourselves as a community of professionals, part of our job is solving system issues. We can't just go to work every day and see one patient at a time. We have to participate in the tough work of running the healthcare system. And in Ontario right now, that's hard because, the relationship, as you know, Steve, and you've talked about this on the show, has become really toxic between government and physicians. And I have a lot of sympathy for the anger that doctors are feeling in Ontario right now. I don't think that unilateral action on the part of the government is a good idea. I don't think that it creates the kind of environment that we need for health system improvement. And I also think physicians need to be willing collectively to take on the responsibility of partnering with government to make the healthcare system better. And that's going to require a new definition of what it means to be a professional for ourselves as a community of doctors. It's something that I think is critically important, or we will never be able to achieve all of this.
The name of the book is Better Now, 6 Big Ideas to Improve Healthcare for All Canadians. Dr. Danielle Martin, good to have you at TVO again.
Thanks, Steve.
Thank you.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.